Good afternoon, everybody. This is Emily Clark. I'm a knowledge broker for the NCCMT, and I will be your host for today's peer-to-peer webinar brought to you by the National Collaborating Center for Methods and Tools. Thank you so much to everybody who has joined us today for the webinar. Before we get started, we will quickly review a few housekeeping items. Please see the chat section on the bottom right-hand side of your screen in WebEx. You can use the chat section to post any questions or comments you may have during the webinar. We will have designated open Q&A sessions at the end of each presentation, but please feel free to post any questions or comments that you have during the webinar. When you post in the chat section, please post your comments to all participants so that all of the participants and all of the panelists are able to see the questions. And some participants may have the same questions that you do. Today we do recommend using a wired internet connection as opposed to a wireless if that's possible. And if you have any connection issues today, you can use the WebEx 24/7 helpline, which is posted on the slide and will be posted in the chat section. And you should see Vivian Chen is one of our panelists as well, and she's available to help with any technical issues like sound clarity or anything like that that you might be having. After today's session, we will be posting today's presentation slides in both English and in French, as well as the English video recording on the NCCMT website. The link to this page is posted in the chat section. We'll start with one of our polling questions for today. We're just hoping to get a sense of the audience that is joining us today. We're wondering how many people are watching today's session with you. Please indicate if it's just yourself, if you have 1 to 3 people joining you, 4 to 6, 6 to 10 if you are in a larger group. You can answer this question in the poll question panel on the side of WebEx that should pop up. And just remember to hit submit so that your answer gets recorded. So today we can see we do have, most people are joining solo, but we have a couple of groups of with 1 to 3 and a couple of larger groups as well, which is really wonderful to see. So thanks to everybody who has joined. I'm happy to officially welcome everybody to the second webinar in the peer-to-peer webinar series. This is a new webinar series from the National Collaborating Center for Methods and Tools designed to share success stories in evidence use in public health across Canada. And we want to help demonstrate that evidence-informed decision-making is achievable by anybody who is working in public health by sharing some stories of people who have been successful. For those of you who may be unfamiliar with the National Collaborating Centers, we're actually one of 6 across Canada. We're all funded by the Public Health Agency of Canada. We here at the NCCMT are located at McMaster University in Hamilton, while the other NCCs that you can see on your screen focus on specific public health content areas like environmental health or determinants of health. We focus on improving the access to and use of methods and tools for health professionals in practice in Canada. So we're not content specific, but we focus on resources that can be applied across all sorts of different areas of public health. We do offer many products and services through the website. The Registry of Methods and Tools is a database of resources that support knowledge translation in public health. Some of our online learning opportunities include our learning modules, a core competency tool that links resources to the core competencies for public health, and a rapid review guidebook that details the steps for conducting a rapid literature review, among lots of other online learning things. We also offer in-person workshops, which are great opportunities to build capacity in your department or in your organization. Public Health Plus that you can see at the bottom there is an online collection of quality appraised studies and reviews, all relevant to public health. They're all curated through McMaster. Our video series include the Understanding Research Evidence series, and those are nice short videos that explain statistical concepts in really easy to understand animated 5 to 10 minute videos. They're good refreshers on topics and also give you some of the tools that you need to help explain those topics to others. And finally, we also engage in quite a bit of networking and outreach to promote evidence-informed decision-making across the country. Today's webinar will highlight some very interesting stories related to evidence-informed decision-making, one of which is actually featured in our EIDM Casebook. This was launched recently, so this summer. The Casebook features a total of 9 success stories of evidence use in public health in a whole bunch of different settings and contexts. It is available at in the link posted in the chat window, so I do encourage you to check that out if you haven't already. And now I'd like to get on to our presentations. So I'd like to formally introduce our first presenters. I understand you will be introducing yourselves, but it is my pleasure to introduce a team from the City of Hamilton Public Health Services. They're in NCCMT's backyard in Hamilton, Ontario. And I want to thank you so much for joining us today, and I will pass it on to you. Amanda, I'm passing slides on to you.
Perfect. Thank you, Emily. So we've entitled our presentation, Establishing a Community of Practice to Build Knowledge and Skills in Evidence-Informed Decision-Making Within a Public Health Setting. So we had a big team that worked together to create the Casebook submission, which Emily mentioned is live now, as well as everyone here contributed to creating this presentation today. Today you'll hear from 3 of us in terms of actually speaking. So my name's Amanda Harvey. I'm the Competency Development Specialist. And then you'll hear from Juji and Faye as well. And Suzanne and Michelle are also with us to answer any additional questions that you might have. So before we get started, we wanted to discuss our objectives for today. So by the end of our presentation, we hope to illustrate how the City of Hamilton Public Health Services is implementing evidence-informed decision-making, discuss barriers to implementing EIDM initiatives and how we overcame them, as well as to entice webinar participants to start or enhance their EIDM strategies. So before we get into the meat of our presentation, we wanted to hear from you. So we'd like to get a poll started. So how ready are you to use EIDM? So maybe you're asking, what is EIDM? Maybe you've heard about it but don't know where to start, or maybe you understand it but haven't put it into practice, or you use it sometimes but not consistently, or you use it all the time. So please make a selection and submit your poll, and we'll give you a few seconds for that. So hopefully people have submitted their polls there. We're actually going to try and broadcast these results so that people can see the distribution of the participants on the line. So while we wait for that to come up, we just wanted to tell you that in Hamilton, in general, most people in our organization were at the point where most understood what EIDM was and were sometimes using it in practice, but it wasn't being implemented very consistently. So as you can see on the results that you guys have submitted, we do have a range, but it looks like the majority are that you are sometimes using EIDM in your work, but not consistently, so somewhere around the same as where Hamilton was. So that's great. So the next question that we have is, how ready is your organization to use EIDM? So maybe it's that they don't want to hear about it, or it's on their radar, but nothing has been done so far. Maybe they've taken steps to incorporate EIDM, something like training maybe, or EIDM is supported and encouraged at your organization, or EIDM is an expectation. So again, please just select one of those options and submit a poll, and then again, we'll pull up the results once we have them. So I'll give you a few seconds for that. So again, just to let you know where Hamilton was on this, basically before or when we started with this casebook submission and the kind of the start of our story that we're going to tell you today, EIDM was kind of on the radar, but not a lot had been done. But they had just started moving into that next step where training was just starting to take place. So that's where we're going to start our story from here in Hamilton. So again, it looks like we have a few different options that people have selected, and quite a few is that EIDM is an expectation. So that's great to hear that people are using EIDM. Oh, good. So hopefully, based on our presentation, you'll be able to pull out some things that will work in your organization for all of these people. So I'm going to now pass it off to Juji, who's joining us from BC today, to get us started on our background.
Thank you, Amanda. Good morning, everybody. Or actually, I guess it's almost good afternoon for you. Still up in BC. Back in January of 2015, I was supported to attend a knowledge broker mentoring program put on by the National Collaborating Center for Methods and Tools. So 6 interdisciplinary staff from Hamilton participated. And at that time, there was no clear direction on the role of the knowledge brokers within our organization to build capacity around evidence-informed decision-making. So I asked myself, well, what role can I play in creating a sustainable and supportive environment that would enable ongoing skill and knowledge development for me as a knowledge broker, as well as support capacity development of nurses and other public health staff managers to access, critically appraise, and apply research to their practice. So hence, a community of practice was established. We began small with 4 staff and a mentor from the National Collaborating Center. And the community of practice continued to expand, and that was through peer-to-peer recruitment, basically word of mouth, as well as staff presentations and workshops. Early on, the participants developed terms of reference to identify shared goals and objectives to ensure that the time spent was relevant to our work and our needs. First, our first objective was to develop staff capacity to appraise relevant public health research by using various appraisal tools such as the AGREE tool, Health Evidence Quality Assessment, AMSTAR, and CASP. Our second objective was to develop staff capacity to apply tools that support EIDM practice, such as the PICO tool and the Applicability and Transferability tool. And finally, to support program teams in their efforts to appraise research and use EIDM, we use peer-to-peer consultation, presentations, and workshops in collaboration with NCCMT. Now, there are a number of barriers we encountered along the way, but before we discuss how we overcame our barriers, we want to check in with you to see which barriers you face or think you will face in implementing EIDM. Please consider each of the barriers on the list carefully and check all that apply to you and your organization. And for any that aren't listed, please use the comment box. We will give you a minute to make your selection. So just to give a little assistance, for a couple of them, we thought they might need a little clarification. Under the mentor expertise, it was people that could support EIDM initiatives in your organization, like a community of practice. The silos in your organization, just our staff or programs working in silos, that can definitely be a barrier. And burden on key staff, such as mentors, research staff, librarians. So just to give a little more context. Just waiting for the responses to come up.
It looks like there are still quite a few responses coming in. I think people are considering the responses. And we just closed the poll, so hopefully that comes up in a few seconds.
All right. Yeah, so in Hamilton, to some extent, we faced each one of these barriers, and we're going to present to you sort of how we overcame those barriers. But let's just see what we've got from you guys. All right, so they're pretty spread out, really. Yes, you've got widely spread out. So yeah, a lot of barriers addressed, and there are a lot of barriers along the way, and it was a real process for us. So thank you for sharing your thoughts. I will now pass you on to Faye, who will present each barrier and how we have addressed it. Thank you.
Thank you, Juji. The community of practice in Hamilton is thriving. Barriers were addressed through many of these recommendations, and they will probably also help you because you have, most of you have experienced most of the barriers that we experienced. So let's look now more closely at each of the recommendations and what barriers they help to overcome. As you can see on this slide and in the next few slides, we have listed all of the barriers, and the ones that were addressed by the recommendation are highlighted in blue. This way you can keep an eye on any barriers that you have identified in the previous poll. So let's get into the first recommendation. Management support in the beginning of our process was critical to addressing many of these barriers. Supportive managers help to encourage increased participation by their staff, and this support often extended to other staff on other teams. Management support resulted in improved awareness, overall visibility, and buy-in of EIDM, which led to a culture of accepting that EIDM was in fact a necessary process. At the outset, we were lucky to have a well-known and respected mentor from NCCMT to mentor the group. This was important in building the confidence of the knowledge broker and participating staff. Her expertise and involvement helped to promote the importance of this initiative with staff and to empower staff. As our group evolved, the mentorship was transferred to someone on our team in public health. Volunteer participation actually increased staff commitment because staff were invested and interested. If people didn't have time to participate, it was okay. And even if people did not have time to read the article, it was still okay to attend the sessions and learn more about the process. We had to determine the participant needs to drive the focus and goals for our community of practice. And you can see by the number of shaded blue here that when we focused on key questions that needed to be answered in our staff's work, that many barriers were then alleviated. As mentioned earlier, the terms of reference was established early on and revised annually as a group to ensure that it reflected our changing needs. In addition, it gave us legitimacy in the eyes of our participants and the organization. Tracking participation included the number of attendees, documents that were appraised, and tools that were used. This was important in helping to evaluate what we had done and monitor the level of interest. Tracking participation is also important to advocate to management and the need for the community of practice. We needed to empower staff to take turns leading the meetings. Staff were asked to pitch in when the knowledge broker was busy or if they had a particular interest in the evidence being presented. This helped share ownership and burden of preparation. Knowledge transfer to those not able to attend EIDM sessions helped to support other staff needs and further support the need for the EIDM process. For example, we looked at evidence about how to reach parents unpacking a healthy school lunch, and then we shared the successful approaches with our school public health nurses. Another example is we presented our actual case examples during our staff division day, and this helped share the importance of EIDM with all staff. Now that we have looked at some of the recommendations that helped us, Amanda will talk about what has happened since.
Thanks, Faye. So since the Casebook, the community of practice is ongoing and has new leadership that's stepped up to take it on. So because of this, staff are able to apply the concepts that they've been developing to their work. EIDM has also become an organizational priority for us, and so a plan has been put in place to further embed EIDM into the work that we do here. And part of that plan was to start training more staff. So in 2017, 20 more staff were trained at NCCMT in a week-long training event. And another part of the plan is to use consistent tools within the organization so that EIDM will be embedded properly into various processes such as our op planning, our Board of Health reports, those types of things. An example of that we've already done was that here in Hamilton, we looked at the new standards and we used evidence to determine how we were best going to meet the new public health standards. And we actually engaged the EIDM trained staff, the ones that we trained in 2017, to help them use their skills in a real life situation that would be used. So in terms of next steps, the fact that EIDM is now an organizational priority for us. It's allowing us to continue to build knowledge and skills among staff in how we actually use EIDM. So the plan is to continue to train staff and encourage EIDM integration into everything that we do. An evaluation is planned for how we're doing so far and used to inform our future steps. But in the end, what we're really looking for is culture change so that EIDM just becomes a part of our work and becomes that expectation that some of you already have. So that's kind of our story. And through this, now that you've heard from us about how the City of Hamilton is implementing EIDM, what barriers we face and how we alleviated them, hopefully we have enticed you to try and start or enhance EIDM at your organization. So we would like to get a little bit of a conversation going. So we have some questions here on this slide. Now that you've heard our story, what are your next steps? Is there anything that you're going to bring back to your organization to try, or any other questions for us? So please take a few minutes and think about what you can take from our story and apply to your organization or your work, and please put that in the chat pod because we'd love to hear other people's experiences as well.
Wonderful. Thank you so much for that presentation. I do hope we hear some comments, especially as a lot of people did comment that EIDM is an expectation within their organization. So I'd be really curious to see how that gets implemented. So just a reminder that you can use the chat window to post comments. Make sure that when you hit send, it's directed to all participants so that everybody can see your chats. And we've actually got a question coming in. I'm not sure if you're willing to take a question now.
Yeah, absolutely.
Yeah. So the question was, what are some specific examples on how you engaged management?
It's Juji. I think initially the engagement of management was really done through actually going to management team meetings and talk about what we were doing. So really being transparent about community of practice and what our intention was. And of course, we talked about having in terms of reference, which really clarified what we were doing. And also, I think the other thing that helped that initially higher up in the director level, there was that sort of agreement that the department was interested in moving towards EIDM. So I guess this was seen as an early grassroots effort, and management wanted to support it. So I think that initial support was really critical as well.
Great. And it looks like we've got a number of questions coming in. So the next one was, what kind of support and mentoring does NCCMT provide? Maybe you could talk a little bit about your experience, and I can talk a little bit about what we do offer.
Amanda, do you want me to do that one?
Sure, you can talk about the knowledge brokering piece, and if you want, I can add in the training piece after.
Okay, that's great. So for the, because I was enrolled in the project for the Knowledge Broker, the program, our mentor kept saying that if there was any support that we needed during the time of the program, that we were, they were more than willing to support us. So there was no sort of specifics around what that support looked like, and really she was very willing to support us in starting a community practice and offered her time to attend and provide that guidance and really help build our confidence. And I think that was probably one of the most important things, because eventually she would be leaving and we would have internal mentors take over. So that's what it looked like from the beginning. Yeah. Amanda?
So my role is to kind of move this EIDM initiative forward, and so because my role is in competency development, something we've been working on is EIDM, and so we reached out to NCCMT to get further training for our staff. And so we actually spent 5 days in a training with NCCMT, and they provided all sorts of knowledge about a lot about critical appraisal skills for our staff, and then have been available to answer a lot of questions after the fact if we had any.
That's great. And then just to elaborate a little bit on what NCCMT does have to offer, we are available anytime if you have any questions related to EIDM, specific questions about research studies that you're looking at or reviews that you're looking at or conducting. You can always email us at nccmt@mcmaster.ca. I think that email will be provided again at the end of the presentation. Our knowledge broker will get back to you usually within 24 business hours. We offer workshops. It is like a cost recovery basis, so there are small fees involved with that. And we're generally available to do things like organizational assessments to help organizations prioritize what directions they need to go and what they should focus on as they start or continue their EIDM journey, depending on where they are. So it's really quite flexible. We have almost 10 years experience now in helping provide this type of support. So we're very open to work with you in terms of what you're looking for. So I hope that has answered that question. The next question that we had was, I'm just wanting to learn more about it and then see how I can incorporate or use it. And I think they're referring probably to evidence-informed decision-making. So they're looking for some practical examples of how it has been used and that those would be very beneficial. I'm wondering if you could maybe talk a little bit about how you've used EIDM in your practice since starting this community of practice.
It's Susie again. So I'll start from the community of practice, and maybe Amanda, you can add something on after. I think what was really the best part about getting together as a group on a regular basis, we met 9 to 10 times a year, was that the research that we looked at was relevant to whatever we were working on. And even if it specifically didn't focus on what we were working on, the conversation about its application to practice was relevant to everybody at the table. And it was a really great table to be at because everybody felt very equal around the table and there was no dumb questions. We were all at different phases of our learning. We all had different expertise to share at the table as well. And I think that relevance to practice, and as we kind of would meet month to month and sort of have aha moments where we would say, I kind of get that now. I understand that everybody had these different aha moments along the way. That just kept feeding the community of practice and making us realize how important it was for us to practice and to talk about it and share. Amanda?
Sure. So in terms of practical examples for us, the biggest one for the staff that we trained in February of 2017, they got to use their skills that they learned in the review that we did for the public health standards. And so they got to work with evidence leads from our FE and evaluation team and the managers that were on the different projects that we were looking at, and actually get to use their skills to do title screen and abstract screens and critical appraisals and be able to actually make recommendations back to the work groups that we had around those about what the evidence was saying and what the recommendations should be moving forward. So I think that was a really good concrete example of how to use these skills.
Great. And actually the next two questions are quite similar, asking a bit about the evaluation process. What type of evaluation process will you be conducting in regard to the uptake of EIDM, and how you've measured buy-in and participation in EIDM?
Okay, so the evaluation, because this is a very new initiative, we haven't fully fleshed out exactly what the evaluation plan will look like. So if anyone has any strategies that have worked in the past, I would be happy to hear them. We did do an initial scan, or I didn't do it, my predecessor did it, using the Is Research Working for You tool. And so we will eventually do that again later to see if there was any change on how they felt going through that tool. Right now, I am creating an evaluation just for the 20 staff that we have trained to determine how the process went for that first example of them using their skills in this standards review process. And so we're going to do just an evaluation with those 20 people to determine their skill level and how they feel confidence in their skills and the processes that were used as well as the tools, and determine if there's any other training gaps that we have to fill. So that is the more immediate short-term evaluation that'll be done, but there are plans being made to do a broader evaluation at an organizational level.
Great, and I've just posted the link to the Canadian Foundation for Healthcare Initiatives Is Research Working for You tool. This is a really fantastic tool that organizations can use to assess where they're at in terms of EIDM and come up with priorities moving forward. NCCMT has used this quite a few times in organizational assessments, and it has been very effective. So we do recommend that one quite highly. I've posted the link to the NCCMT's Registry of Methods and Tools, our posting for that one. So hopefully that is useful for someone as well. The next question, and I think you've touched on this as well, we still have a few minutes for questions. So do you have a practical example using EIDM in your practice setting?
Hi, it's Juji. I'm wondering, Michelle, would you be willing to talk about the presentation that you made and your practical example from your work?
Sure, yeah. So this is Michelle. So I was working on the substance misuse prevention team back at this time, and I had a question from one of the school nurses about using fear-based tactics to address substance use in high schools. And so historically our message has always been fear-based tactics don't work, and so don't use them. But I decided to do a literature search to see, what the evidence was saying, and I actually found that in terms of substance misuse, fear-based tactics were shown to not have a detrimental effect the way that it's always been kind of the culture, right? Like to say that you shouldn't use fear-based tactics because it'll backfire. So I found that actually wasn't true. And so the message that I had for the school nurses was, it wasn't going to be a detrimental thing, but it also wasn't effective. So based on that's how I used evidence in my role. So hopefully that helps with giving you a practical example.
Great, thank you, Michelle. Sounds like an interesting project, actually, so that sounds really neat. And then we have one more question. I think we'll do this last question and wrap it up with our first presenters and move on to our second presenters. There will be time if you think of any more questions for the Hamilton team. We will have, again, an open Q&A after the second presentation as well. But the last question that we'll take for the Hamilton team right now is, I think this is interesting. Based on your experience, have you found that applying EIDM in some areas or topics could be easier and more feasible than other areas or topics? And if so, please provide some examples.
Wow, that's a good question.
It's a good question.
Yeah, I'm just trying to think. I mean, because we had some of the topics across our table that were bigger topics where we're looking at the use of lay like health workers, or what are they called again, Faye? The community health workers, really in terms of working with populations versus a very specific example like Michelle's example. So I guess the question again is, can you just clarify the question again? Was some more difficult than others?
The question would be, are there areas or topics in public health that are easier to apply EIDM to than other areas?
I'll get my
Sorry, keep going, Juju, if you want.
No, I'll just give a quick perspective. That was a challenge for us is in looking at quantitative or outcome-based sort of research. Like a lot of our work in public health, we have sort of process indicators, but we really don't have outcome, evidence to say that we've really changed, for example, head injuries in our community, or we've changed levels of chronic illness. And so when you're looking at the evidence and then trying to posit in a way to present a report to, say, our Board of Health, that is definitely challenging. So some of those sort of more nebulous issues or grayer issues are definitely more challenging than some of the more concrete issues where you can really look at tangible statistics that might be useful.
I would echo that. Just anecdotally, when we were looking at some of the work when we were doing our standards reviews, it was interesting to see the difference in the EIDM, even just the questions that were coming out for things such as environmental health versus some of the much bigger health promotion topics, just based on the evidence that's available and being able to really narrow down a specific question to really use for EIDM, so whether that's for our searches. So I think that it does vary based on the topics about how easy it is to actually do, but I think it's possible to do for all of it. It's just the strategies that you need to use. And for some of our health promotion ones, we really had to kind of narrow our scope because there was just so much research out there.
I wonder if the amount of research would possibly really speak to this. There are some newer topics where there hasn't been much research yet, and those would possibly be more challenging as well. But I think you're always looking for the best available, even if there isn't that much available at the time.
And Emily, one thing to add to that, I mean, if we're looking at the framework, it's not even all just about the research. It's having that discussion about our community and resources and all those things, which we had some excellent discussions when we started to get into the A&T tool.
Yes, and that's a reference to the applicability and transferability tool that you can find through the NCCMT. I'll see if I can post a link in a few seconds. And that's a tool that lets you review the evidence that you have found in the context of your community and political setting and your organization, and determine whether or not this is a program worth starting or stopping in your practice. So that's great. So we're just about on schedule now to move on to the second presentation. Thank you so much to everybody from Hamilton, Faye, Amanda, Juji, and Michelle. We heard from you as well, and everybody else on the line. So I did find that a really nice and comprehensive look at some of the barriers and how these were addressed, and some of the examples that you gave were really wonderful. So I do appreciate that. Moving forward, I am very excited to introduce to you Wendy Timmermans and Sandy Phillips from Alberta Health Services. Wendy is a care manager and Sandy is an area manager at Alberta Health Services. So this is a story that wasn't actually featured in the casebook, although now I'm wondering if maybe there's a way to fit it in, and maybe the second edition. I came across Wendy and Sandy at the CHNC conference earlier this year and sat in on their presentation and thought it was a really excellent example of using community-based evidence in order to improve care. So I invited them to present at this webinar, and I'm very, very happy that they have accepted and are here today. So without any further ado, I will pass it on to Wendy and Sandy. Thank you so much.
Thank you. So thank you for the great introduction, and thank you for inviting us to present our presentation to you. What we'd like to share with you is our all-inclusive resort to change. And so like we were introduced, we'll briefly tell you a little bit about us so you understand our context. So I am the area manager of public health of 4 rural and 1 urban public health community centers within the Calgary zone in Alberta.
And I'm Wendy Timmermans, and I am the care manager in that same area. Some of our communities are amongst the fastest growing within the Calgary zone and even in Alberta. And so we've had really significant population growth that really led to challenges meeting client needs for vaccination appointments for infants and children. and really increase the distress amongst our staff member to meet those needs.
So this group, our Access Improvement Measure, we embarked on with a leadership team and expert facilitators to utilize the Access Improvement Measure, or we call it AIM, process to help us assess our current practice and identify where changes could be made to improve efficiency or to address bottlenecks in our service. And so our group included?
It includes our clerical staff, our public health nurses, and us as managers, of course. The change needed to happen because things weren't working well the way they were, and it really needed to include all of our staff and thus and our clients as well. So that's why we called it an all-inclusive resort to change. So, of course, the only person who likes change is a baby in a wet diaper, but what we found is, of course, as you change a baby into a dry diaper, the baby is happy, and what we found, change is not always easy, but as we went through this process, our staff became much more engaged and really happy to be able to be involved in the process and to create the changes that we did.
So while we learned, the slide is not moving forward here. I'm not sure why. There we go. While we learned the Access Improvement Measure process, which took us from January 2014 to November 2014, there's a group from our Community Health Center in Thornhill that participated in the actual learning. So there was us as managers, our vaccine coordinator, we had our secretary, a frontline nurse, and our clerical admin support join our team, and we learned the process and brought all the information back, and then we implemented different ideas and followed the AIM collaborative to identify where we could make some changes. So we needed to identify some really specific measurable goals for client access and office efficiency and improve our clinical care. So to start that, we needed to build a flow map to understand what was happening when clients wanted to access our service.
So I just want to go back for a moment. There were 13 AIM teams across the province, and we met with them on a fairly, 5 times during this period of time from January to November. And so we really had high-level analytics and very skilled people who were helping us through this process because we really needed that assistance. So this is one example of a process map and how we tried to determine areas really how our processes were carried on within our clinics and how we could possibly identify bottlenecks and create change. So this is just an idea of how when the client presents either in person or on the phone and says, I want to make an appointment. So we mapped out all of these processes for somebody who was already known in the clinic, for somebody who was known within Alberta Health Services, for somebody who is unknown coming to us brand new. And we did this for every process that we did from check-in to check-out after the client's appointment was finished.
So this is one slide of probably 7 from the time they present or identify to when they could actually book an appointment and be seen. And it was very mind-boggling, the bottlenecks there were. So what we needed to do, we needed a starting point. We needed to measure. We wanted to know where we were and where we wanted to go. And our current system couldn't capture the data that we needed, so we used tick sheets, many tick sheets to assess our activity, supply, and demand for our vaccination clinic appointments. And then we implemented what was called a PDSA, and it's a model for improvement. It's a Plan, Do, Study, Act cycle. So we knew that if we wanted to make some change, we couldn't expect different results if we kept doing the same thing over and over again. So sticky notes became the norm. Staff identified where they'd like to see a change and other issues related to client care. These were grouped into themes, and collectively with the whole group we triaged them and selected what we thought we could do something about. And then the goal of AIM is to ensure that we can either sustain some of the things we wanted to trial or spread it to the entire zone. So in Thornhill,
our AIM initially was to improve access. So we needed to reduce our wait times from 65 days to 42 days by November 1st, 2014. The challenge is, of course, if you have a newborn and they phone immediately to book an appointment, they can get in 65 days from that point. However, we know, and the immunizations need to be timely for our 2, 4, 6, 12, 18 months in preschoolers. And so obviously there was a huge issue. So, and coincidentally, as we started this process, we were given a 2.0 full-time equivalent augmentation and 100% backfill. So by May 26th, our wait times are down to 6 days, which is really, really wonderful. However, that was somewhat artificial because that augmentation and backfill was discontinued and our wait times went way back up to 67 days. And they're still very high because we have a really rapidly growing population and our staffing equivalent really has not changed. So that's still a concern. However, our office efficiency aims have been really successful because even though people are waiting a long time, what is it that we can do in the office to make the experience really good and to help our clients feel happy with the service they're receiving and to really help our staff feel that satisfaction as well. So our goal was to increase process efficiency, the amount of time that the clients can actually spend with the nurse in the clinic, and to decrease and address the bottlenecks in the clinic process from the time the client checks in.
So we also wanted to identify what our clients thought about our service. So we handed out approximately 202 surveys in a 4-week period, and we wanted clients to rate us regarding the services they provided, what concerns they had, and suggestions for improvement. So you can see that many of the clients were very pleased with our service, and they thought the amount of time they spent with us and the information we shared was right on. However, they did identify things that they were very concerned about. The fact that they waited too long to get an appointment, that they had difficulty getting through the phone system to book an appointment, that they waited too long on hold on the phone, and also they waited too long in the waiting room to see the nurse.
So we had some challenges before we even got, the nurses even were able to address the clients. So how did we engage our staff? As we've mentioned with our Plan, Do, Study, Acts and such, we had an idea parking lot, and that was a place for staff to document their suggestions for improvements and efficiencies. And we had a PDSA board. When we had actually put some of those suggestions into action, we made sure that we kept everybody up to date on the information. There wasn't anything lost, and it really ensured that everybody was curious in seeing how we were proceeding. We also did a healthcare team effectiveness analysis, and that was designed to really highlight the areas of our teamwork and collaboration and how we might be able to improve that, but and to really increase our efficiency. And we did really well. Our staff, we have a really positive staff. We shared our AIM information at all of our staff meetings. All of the staff were involved in implementing the PDSAs because all of our staff works through Well Child Clinic. And we had a storyboard that was kept up, that had our up-to-date information that we made available in the clinic for anybody who was interested in seeing it, and we also presented those at the larger AIM learning sessions.
So just to identify our reality, we have 2 clerks at the main reception that greet clients and register them, check them in when they come in, and get things ready for them. They answer the phone, and then they also book appointments on the phone and do the checkout process. We have 2 weigh stations, and we have up to 8 Well Child clinics running at the same time. So 8 nurses vaccinating at the same time, 2 weigh stations. So when we looked at PDSA, some of the things that our staff identified is, well, maybe if we had the baby undressed and ready to go when the nurse met them in the waiting room, it would be quicker to move through the weigh stations. Could we stagger the appointment times? And maybe how can we address the bottleneck at the weigh station? The other thing we looked at is the check-in, check-out process for clients, and what can we do to simplify the information we shared with clients? As well, is there a bottleneck from when the clients bring in their vaccination information, so new clients, to when we can actually book them appointment? And what about our no-shows? How big of an impact is our no-shows, and what is the cost to our system? Can we look at our schedules, wait lists, or even our phone tree? There was nothing that was sacred. So in an ideal situation, so the AIM study uses this process. In an ideal situation, we the demand, so the amount of requests for vaccination appointments, equals the ability we're able to supply, and then the number of clients coming in. So the demand is the workload. So the demand is actually the clients calling in or coming in and requesting an appointment. And it's measured on the day it's done. Even though they may be wanting to book an appointment 2 months in advance, over the course of the year, it averages out. And there are many ways to measure the demand. And you can see that we looked at that whole process. So we thought, okay, well, actually, how much appointments should we have? And so this is a really busy slide. And in summary, we looked at what our birth rate was. And so we saw that at this given month, there was 257 births per month in our clinic area. So 2-month babies require 2 30-minute appointments. And then any infants coming in that are 4, 6, 12, or 18-month-olds require a 30-minute appointment. So if we calculated that out, we could see that we require around 4,600 30-minute appointments to meet that demand in 12 weeks. So what is our staffing like? So we looked at how many appointments could we provide if all of our staff attended all of the clinics that they were scheduled for. And you see we could provide 4,300. So we are already short 324 appointments in 12 weeks. Then what about our preschoolers? So we looked at that and we found we are short additional appointments. So we are actually short 930 appointments without considering adults that were coming in for 10-minute appointments or people moving into our supply area. And we've continued, like Wendy alluded to earlier, see growth in our area. The supply is the number of available appointments. So that's our planned work. That's the actual, if everybody worked on any given day, that's actually what we could provide. It's not when people are away, it's what's scheduled. The activity is the actual number of people that come in, and it doesn't include cancellations or no-shows. And how we determined measured no-shows is actually a client that did not present for their appointment. Even if they phoned 10 minutes before their appointment to say they couldn't make it, that was considered a cancellation. So we measured the demand, the supply, and the activity every day. And we had, so we figured out in the morning, each nurse was able to do a 10-minute, a 60-minute, and 4 30-minute appointments. And so we had the clerks do a tick sheet to measure the number, the demand, so the number of people requesting and what kind of appointments they're requesting. And then the activity was done by our secretary, like how many people attended the clinic appointments.
So because we really identified that this is very, very useful, our analytics team now takes care of that, so we don't have to do the individual tick sheets, and everybody was very happy. So this slide shows our next available appointment, and you can see the number of days, and for some reason, I don't know why July 16th was really high, but it dropped significantly through the summer when our school nurses were available to help us out with more clinics. And then, of course, in September, when the school nurses went back to their school focus, our waiting times went up very substantially again. And so with AIM, the standard is you measure your third next available appointment, whether that's a 10-minute or 30-minute appointment, it doesn't matter. It's your third next available appointment. So that's kind of our process, and that's what we assessed before we started implementing any PDSAs. So remember, those are ideas from the parking lot that staff identified, and also clients. So what we found is clients complained about our phone tree, and so we listened to it. It actually took 49 seconds from the time they called us to when they could actually speak to a live person. So we tweaked that, and now it only takes 20 seconds from the time they phone in to when they can actually speak to a person to either book, cancel, or speak to a public health nurse. And they're quite pleased about that. And we kind of chuckle when we phone other offices and realize they haven't quite changed their phone tree message just yet. So one area that we thought, looking at, we saw how we mapped all of our activities by the clerical when somebody called in. We thought we'd look at the chart verification because we thought perhaps it was taking too long to, from the time that a person presented their immunization record to the time that it was verified and then able to make an appointment from that. And as we went through it, we realized that actually within a week everybody could have an appointment. So we were very pleased with that. And it's really good to say, hey, you know, we've identified that that is one thing that we're doing really, really well.
So we looked at our check-in, check-out process. Like we mentioned earlier, we had 2 clerical working at the front. Could we streamline this and have one clerical check in the clients and the other clerical check out the clients while both of them manage the phones? And so initially when they trialed this, the clerks, they didn't like it. It was, they found it too confusing, clients didn't know where to go, and so forth. So we stopped doing that process, but reintroduced that towards the end of our AIM initiative, and they actually trialed it again, put up signage to direct clients, and found that the process works extremely well, and they continue to use it to this day.
And of course, our clients are familiar with it now, so it works really well. So another thing we looked at was our waitlist management, because what was happening when we started this with our long wait times is that clients would call in and say, I need an appointment 2 months from now, and unfortunately we only had one that was available 3 months or longer at that, well, not 3 months, that's a long time, but whatever, they couldn't get in at the appropriate time. And so they would continually call back to see if something had come open, and we do hold clinics back just for until a couple of weeks before they need to be opened, just to ensure that we have adequate staffing. We've covered vacations and such. So what we did, we said, well, how about you phone in, we'll make an appointment for you, and it might not be the appropriate time for you, but we'll put you on a wait list, and then as appointments become available, we will call you back and book your appointment. And so that's been really successful because our clerical are not inundated with a huge number of phone calls. And our clients are much happier knowing that they have an appointment, they at least will get in, but they can anticipate being in much sooner.
And so we also, when clients go on the wait list, they identify whether they can come on short notice. So if we have a cancellation or, let's say, a 2-month is not shown up, perhaps we can get somebody that lives close by to come in for at least a 30-minute appointment. So we looked at, well, what happens? Could we streamline things in the waiting room and have another nurse or another personnel weigh and measure the baby before the clinic nurse comes to get the baby for their vaccination process? And so when a nurse did the visit without the weighing and measure, we found on average the nurse that does a clinic appointment is 29.8 minutes. So, but in total, when she did the weighing and measuring, it was an average 32, almost 33 minutes. When we introduced another RN to weigh and measure the baby, it took, the whole appointment time took 41.5 minutes, because we found that the nurses in the clinic room wanted to do that assessment that was already done by another nurse. So when a nurse starts, greets the clients, that's when her assessment starts. So we found it was more efficient, the process we are currently using, each person doing their own.
So another issue that we had was the nurses were coming out, they were ready to take their next client, and we need the babies to be undressed. And unfortunately, a lot of, you can see the numbers there, a lot of babies were not ready to be undressed, or were not ready to be weighed and measured at that time. So we said, how can we change that? And so it was thought, clerical after check-in, right, thank you. Now say, can you please get your baby undressed to a dry diaper? The nurse will be with you shortly. And we also put up a poster in the waiting room to please undress your baby to a dry diaper. And it's just much faster because, of course, if babies are not undressed, who knows, they may need a diaper change and everything else before they're ready for the nurse. So this was a very successful PDSA.
The other thing that we looked at is we have this resource called Healthy Parents, Healthy Children. It's a 2-book resource and also one called The Early Years. What if we made bookmarks and we handed them so each client gets one either when they're pregnant or when they present for their first immunization appointment, or they get an online access. So what happens if we streamline the information we were giving them and based on the regular questions and concerns that we saw coming forth in clinic, could we develop a bookmark that would identify clients, help clients identify where these questions can be answered, and then we can really focus on their concerns and not have to worry about other information we wanted to share. And the initiative has been really successful.
So another thing that we were looking at was the cost of no-shows, because we knew that the cost was high and we knew how many no-shows we had, and it was quite significant. So we measured the no-shows and determined the cost for July, August, and February, and we included clerical time as well as nurse time in that. And we posted these in the waiting room and shared them with our staff, of course. And it's, when you think of how tight our budgets are and how accountable we need to be, it was really challenging, but really effective to show everybody how much it actually costs. And we thought maybe that would make people reconsider if they were thinking, well, maybe I just won't go in today, at least helping them think, well, I should phone and cancel that, or I will definitely come in. We had really positive responses from it, but unfortunately, another point of view was presented by our medical officer of health, who felt perhaps we were targeting vulnerable individuals who may not be able to come in for a variety of reasons. So we've discontinued it, but the cost of it is still in the back of our minds always.
So the other thing is, when we looked at our no-shows, we tried to identify, was there a specific age group where we had a high rate of no-shows, and those are the preschoolers that Wendy will be talking about in just a minute or two. But we also looked at, is there a time of day or a specific day where our no-shows were the highest, and what could we do about that? So for whatever reason, we found that Tuesday mornings we had a very higher no-show rate on Tuesday mornings than the rest of the week. So we could reshuffle our staffing and have more clinics open on the days where our no-show rate was really low. And so that's what we've done, and we routinely assess our no-shows at least on a monthly basis to determine if there's changes that need to be made. The other thing we looked at is we know that we are not able to get, given our current financial situation in our province, additional FTE, but is there something we could do with our clinic appointments to give us more capacity? So we assessed our 10-minute appointments and to identify how many were unutilized. And so we found, we assessed 2 different time periods, and you could see from May to June, it was 30% of our 10-minute appointments weren't used, and then from September to October, it was even higher at 43. So we thought, what if we lumped those 3 10-minute appointments together and created another 30-minute appointment? Then we could actually see more clients, and we're not with the same FTE. And you know that we were really thinking, and the stinking part about that is we were introduced to rotavirus, and so we needed the additional 10 minutes to offer that rotavirus vaccine now to the 4-monthers. We also offered to the 2-monthers, but the 4-monthers. So there went our 10-minute surplus appointments.
So another area that we have concerns with is the way that our preschool appointments are booked, and typically we suggest between 4 to 6 years is when the kids need to get a preschool. And unfortunately, most of those are waiting till the summer before grade 1. And what we're finding is that we just don't have the ability to provide those appointments. And what we saw, given our number of preschoolers that we have, we would have to send out 200 reminders a month to balance the demand stream. And actually, that hasn't worked. We're trying automated phone calls, automated dialing, and such, and that's still something that we're looking at, because we do have a large number of preschoolers, and we know in the summertime that those are really high no-show rates for those kids.
A lot of our reminders go out in April, and so they book the appointments for the summertime closer to school entry, and we find that parents forget about them. Even though we do a reminder, they may not be home or they've gone on vacation and so forth. So we're still reviewing that process. But going forward, this is what we rolled out to actually all of the Calgary zone community health centers, and some of them have been rolled out provincially. So we have the Undress Your Baby poster, and that's working really well. Parents, almost 100% of parents have their babies ready in a clean, dry diaper, ready for when we need to weigh them. The bookmarks for the Healthy Parents, Healthy Children resource, I believe that's now shared provincially. We modified our phone tree at various sites, and clients are very happy to speak to live voice pretty quickly. We measured the demand, supply, and activity, and as Wendy alerted to, alluded to earlier, that now is done automatically, and we continue to assess where our supply is greatest. We sometimes can direct clients to access earlier appointments there. We have a waitlist management process that works very, very well. Clients are much happier getting an appointment and put on a wait list, and most of the time we're able to accommodate them to come in earlier. The other thing that we did to address some of the bottlenecks at the weigh station is we staggered our appointment times. So now we have people starting with a 10-minute appointment and the other half of the team starting with a 30-minute appointment. And so you're not wanting to weigh scales at the same time.
So one of the really great things is that we now have a quality improvement committee at the health center, and basically involves absolutely everybody because they're really keen to change. We've also had a couple of our school team and well child team who've submitted requests for research dollars, so not sure what's going to come with that, but they are really, really keen to take on change and to look at ways of improving things. Very positive, really great teamwork.
Yeah. They're not afraid to try new things, and even with the changes, there's a really pervasive positive attitude, and staff are really pleased that we heard their concerns and that there was an effort made to address them.
So we like this slide because you can see this fellow's tried a lot of PDSAs before he came out with the wheel. And similarly, we've tried a lot of things. We don't need to reinvent the wheel because we have tried a lot of things. But if you would like to have more information on that, we'd really be happy to share with you some of the things that we've learned and some of the processes and maybe just a little bit more background. So some of the things we have of, our verification sheets, our client satisfaction, our client suggestion forms, some of the things we did with our staff as well, our early years bookmarks, whatever. So we'd be really happy to chat with you and share some of that with you. We're still very excited about how successful this was. It was a lot of work, but the results were absolutely incredible for us.
So thank you. That concludes our presentation, and we hope that we've stirred interest within you, as our previous presenters have, within us, and stimulate you to look at change in a real positive light. The efforts are certainly worth the rewards. So thank you very much for inviting us, and we're glad to answer any questions that you have. If you'd like further information, feel free. Our email addresses are on this slide. Feel free to email us, and we'd be glad to address them. Thank you very much.
Awesome. Thank you so much, Wendy and Sandy. I really do think this is a really useful approach and a really interesting way to harness some of the, in this case, non-research evidence, where the focus is often on research evidence. This is based on community context and your specific local context, and the way that you've looked at birth rates and looked at your process is really interesting, and I think it's been a really fantastic, and I love that it's been so successful and that you were able to share that for us. So we will take a few minutes now to see if there are any questions or comments for Wendy and Sandy, and then we will open it up again for anybody who has any questions for either of our presenters. I'm curious, was there any resistance from parents from having their babies possibly cold in the waiting room? Was that ever an issue?
Actually, initially they were concerned about that, and mostly it's the 12-monthers where they're maybe more difficult to contain. But many parents wrap their children up in a blanket, and so it really doesn't seem to be a concern. Like there's babies running around, and there's in a clean, dry diaper, and it's room temperature in our waiting room, so it seems to be okay.
Oh, that's great. Good.
Good question, though.
That was our concern as well.
Yeah. Like the whole process has been such an incredible learning, and I mean, it did take us 11 months to go through the AIM process, and we met 5 times, and some days were 2 sessions, and we brought what we learned back to the team, and that's where we said, this is what we learned and this is what we should try. So how do you think we should go about doing this? And it just was a really good initiative.
No, that's fantastic. So I haven't seen any questions come in, so please, if anybody does have any questions or comments for either of our set of presenters, please post those now. I do have a couple of closing slides that I will go over. Oh, actually, we've got one question now. I'm curious how you knew about the various processes to guide your work. Did you work with a researcher or a program evaluator?
We did both. We worked with expert facilitators, and these facilitators were really versed on the AIM initiative. So what they did is when we went for those 2 days of training, or 5 different times throughout the year, we posed, okay, so how are we going to measure this, or what should we measure, or and a lot of things came through our staff identifying, well, you know, this isn't working. You know, it takes so long for the client to get through to book an appointment. And so they guided us on how to assess, really, is that a bottleneck, or what is the bottleneck? So it's through the AIM initiative that we learned how best to address those kinds of things.
That's great. Perfect. Thank you. That was a very good question. So. And the Plan, Do, Study, Act, I believe that it's also available through the NCCMT's Registry of Methods and Tools if somebody's more interested in using that one as well. Somebody has now asked, are there tools, checklists, etc. that you used available to us? Also, is there copyright rules for the undressing sign?
No, there's no copyright rules for the undressing sign. Please go ahead and use it. We've had a lot of fun with that. We can certainly share the tools that we use. I don't believe there's any copyright and if you're looking for something specific, just let us know. A lot of things were around our database, and now our database, we are able to collect the data electronically, but certainly the tools, the checklists, and the way we measured our supply, demand, and activity, we're very willing to share those kinds of things.
Great, that's wonderful. So we do have a couple of closing slides. We'll go through the closing slides, and if anybody has any questions or comments, please feel free to post those in the meantime, and we will come back to them. So we are, at the NCCMT, we are very interested in hearing your stories about using evidence in practice. We have the EIDM Casebook online. If you have not yet checked it out, we really do encourage you to check it out. It's a great compendium of cases where people have used evidence in different ways, in different contexts. And I think one of the highlights is that every author has provided lessons learned and some of the key messages for success. So it's a really great learning resource for you. As was discussed a little bit previously, the NCCMT knowledge brokers are available to help you. We do typically respond within 24 business hours. If you email us at the email address available on the slide and in the chat, please don't hesitate to contact us. That's kind of one of the more fun things that we do is get involved with various projects, and we're very, very happy to provide support for that. Your feedback is very important to us. We have a very brief survey that will pop up when this presentation, when you close this WebEx window, you will have the survey pop up. And there will be another short survey that we will email out to anybody who attended today in 2 to 3 months. So we want to see kind of what's been the uptake of some of the messages that we've shared today. So please keep an eye out for those surveys. They're very, very short, and they're very valuable to us in terms of demonstrating our impact and making sure that we can continue on as an organization. So again, this survey will pop up when you close this window. We do invite you to join us for the next webinar in this series. So the peer-to-peer webinar series was a new series this year, and there will be a total of 3 webinars. So the final webinar in the series will be held on November the 15th at the same time as today. We'll be featuring, again, 2 stories. Both of these stories are also highlighted in the EIDM Casebook. The first one is a group that conducted a rapid review. I know a lot of health units and organizations are looking to conduct rapid literature reviews, and we will be featuring a team that did conduct one, and they will talk about both their review process as well as how they gauged applicability of the evidence that they did find. And the second presentation will be on developing a best practice tool for nurses. There was a group in Toronto, and they found that there was a need for a resource to support nurses. There was a change in legislation of who's to provide support to hepatitis C patients, and there was a need for a best practice tool. So they'll discuss how they came up with that tool to help improve their service there. So hopefully another really, really great webinar, some really great presenters there, so we're very much looking forward to that one as well. There are a number of webinar series that NCCMT provides. The first one I'll highlight is kind of our hallmark series, the Spotlight on Methods and Tools. So this is where we feature various methods and tools that are included in our registry. We ask the author or developer of the method or tool to present. They can present the rationale for it, how to use it, why certain decisions were made in developing it, and we also feature a user story. So somebody who has used the tool can give a first-hand account of how they used it, tips on how to use it, why they used it, what they liked about it. As I mentioned previously, NCCMT is not topic-specific. We do methods and tools for all areas of public health, but we do have a webinar series that highlights some of the more topic-specific methods and tools for the people who are working in specific topic areas. So we've hosted in the past things on mental health or resources for MPH students, or things like healthy weight, or environmental health, health equity, that type of thing. So another webinar series that will start again in the spring. One other one that we have ongoing is our online journal club. Small format webinar. There are, it's a cap of 30 participants, and it's generally you just participate through WebEx. This is one where we encourage you to sign in through the teleconference line as well. And we have kind of a candid discussion about a research article, and we critically appraise that article together. So it's a great opportunity to get together with some experts, practice your critical appraisal skills, get your questions answered, and it's a really kind of a fun, small format, get to know your peers across the country type of webinar. And of course the peer-to-peer webinars, which you are attending today. We've had a total of 2 so far, and the third one will be held in November, and I'm very, very pleased with how this webinar series has unfolded so far. So I've seen 2 more questions pop in, so we will read those out. I think the first one is for Wendy and Sandy. Do you use an automated telephone, texting, email reminder system with clients? Also, how do you track your no-show rates? Is it from your electronic client record system, or is it manually?
So yes, we do have an automated phone call reminder system, and we're moving to a new clinical information system in June that will allow us to do texting. So we do a phone call reminder right now to the number the clients identify they want called. And what was the other question? It was asked about, sorry, I forgot the other part of the question. Yeah, the no-shows. The no-shows are done our database. They're now, we select, there's a process that we do, but they're done automatically. It selects the number of clients that no-showed. So our clerical, at the end of the day, at the end of each clinic, they identify clients that have no-showed. So they just go in and put no-show, and then that's tallied, and at the end of the month we assess, we can assess those, but those are done electronically.
Great, thank you. And the last question that we have trickled in here is, do the NCCMT knowledge brokers consult on the less typical research type evidence, such as the quality improvement evidence that was presented in the second case? And the short answer is yes, we do. We do have a number of tools. I mean, obviously our focus tends to be on research evidence, but our model for evidence-informed decision-making in public health uses all different types of evidence, including community and local context and the resources available, and we are able to support the use of evidence from all of those different domains. So yes, and if you do have any questions, please feel free to get in touch, and we would love to hear from you. So I want to thank everybody who presented today. We had two really excellent teams and I think two really excellent presentations. It led to some really good discussion, and I'm very, very pleased with today's webinar. So thank you so much to our presenters, and thank you, of course, to the audience for joining and participating. I know I've definitely very much enjoyed this. Please, again, complete the survey when you close your window. It should take you just a couple of minutes. We do hope to see you next month at the final peer-to-peer webinar, as well as at some of our other webinar series. So I will sign off, and I will pass it back to the presenters in case they have any extra comments before we wrap up, and we hope to see you again soon.
Thank you. This was a great opportunity to share our homegrown solutions. So thank you for inviting us, and like you'll see, you certainly can contact us if you require additional information or have any other questions. Thank you from Wendy and Sandy.
Thank you.
Great.
From Hamilton. Thank you very much to NCCMT for all the great opportunities and for really enriching our work and our practice. Thank you so much.
Wonderful.